Oh, thank God, so far so good. We are going to be doing part 3 or the third folder of internal medicine. Now it's just 72 questions and it's quite interesting. 75-year-old patient cannot tell the month, notice the age. Very old. Date is old, date and season of the year. So she always carry bundle of belongings, hide things, valuable books, and so on. The fact is, she's old. The word old here is the word senile. Senile. So this is senile dementia. Senile dementia. We have a 17-year-old male patient who is having malaise, complained of malaise, chills, runny nose, and so on. But the patient asks to prescribe him a lot of painkillers and sedatives, tramadol or Superdane that help best, and diazepam. You see, just like the previous case we had in one of the videos, when a patient is suggesting to the doctor the kind of drug that he or she wants, especially if it's a drug of abuse, it's called that this patient is an addict, and in this case, this is an opioid. So we have make a diagnosis is opioid addiction, a patient with opioid addiction. We have a 39-year-old patient, headache, pain in the interscapular region, and started vomiting. Please notice the arterial blood pressure of 180/100. Patient is photophobic, hyperacusis, sensitive to certain sounds, and signs of meningitis. You can see the white blood cells level, CSF is blood, cytosis. What is most likely diagnosis? See, the answer is not meningococcal meningitis. It's something in the history is going to point our attention to it, and there might as well be rash in such condition. Pain in the interscapular region and started vomiting. So here we are thinking of subarachnoid hemorrhage. Don't forget that we said that patients with chronic hypertension can be predisposed to developing hemorrhagic stroke or having hemorrhage. So this is a patient subarachnoid hemorrhage. 26-year-old male patient complains of piercing pain during breathing, cough, dyspnea. So you observe that arterial blood pressure is normal, and yet this pain is piercing pain during breathing. So what do we have further in this case? We have ECG showed no pathological changes. However, infiltrative parts of chest auscultation, both inspection and expression, revealed noise that was getting stronger at phonendoscopic pressing. Alongside with this temperature of 37.3, this is best for acute pleuritis. Acute pleuritis. This is a respiratory disorder. Respiratory disorder. None of these options they actually fit. None of these options fit. All right. Once they are telling you about a patient that is having such an hectic fever with return from India, I checked it up. There was an outbreak of this pneumonic plague. It is caused also by bubonic plague. It's caused by the same organism, by plague, and there are about 3 different forms. So there's a pneumonic form. It is rare, but it's very severe. So in this particular patient, you notice that the cyanotic breathing rate is 24, tachycardic, breath sounds are diminished, and so on. But the patient visited India a week ago. This is a patient with pneumonic plague. HIV displays the highest tropism towards the following blood cells. For those of us that used to like one-line questions, I tell you longer questions are always easier, sometimes, or most of the time. So this is TFR cells, the first CD4 cells. So when they are giving the history of a patient with tuberculosis, When they are telling you about mental test, its reaction is up to 16, positive, and so on. So we have the result of phlogram 2. We have focal shadows at 1 to 2 segments of right lung. Focal shadow 1 to 2 segments of right lung. So already they said it's focal shadows. So this is focal form of tuberculosis. And however, focal form of tuberculosis is usually in specific segments of the lung. If it is infiltrative, it's mostly all over the lung, the size around 1 centimeter, and miliary or disseminated. Miliary will be so small all over the lungs. Disseminated means that they're spreading all over the lungs as well. So this is a patient with pneumonia, but every organism here can actually cause pneumonia. Mycoplasma, legionella, they can cause atypical form of pneumonia. But look at this particular case. The patient works in an air-conditioned room. Now, this is Legionnaire's disease, Legionella. This particular bacteria loves to stay in water, in particular area with moist, and specifically even in air conditioners. So when they're telling you about a patient that the history is in agreement with pneumonia, and they're telling you that the person works under a conditioned room, please think of Legionella. All right. We have 43-year-old female patient. Dyspnea, swelling of legs, abdomen enlargement, and pricking heart pain. You can see tuberculosis, bronchitis, quinsy. Quinsy is peritonsillar abscess. Patient condition deteriorated 6 months ago. Now patient is having cyanosis, bulging neck veins, heart sounds are muffled, and so on. Low voltage on ECG. Radiograph shows a thin layer. In fact, in this question, this is the most important thing. A thin layer of calcium deposits along the left contour of the heart. I'm saying that because we are still going to say a similar question as we move forward in this video. But the fact is, here they are not asking for diagnosis, they are asking for treatment. So the best thing to use as he said, what treatment should be recommended to this patient? I think this is a condition of amyloidosis. Amyloidosis is very common, especially to the heart, and I think secondly to the kidney as well. And this is triggered by an history of tuberculous bronchoadenitis. So when you see calcium deposits, and for something like this, you are going to need the consultation of a cardiac surgeon. So the treatment is going to be by a cardiac surgeon. Please take note of that. So that's the question I was thinking about. We are not going to see further. That's the question. All right, we have a 53-year-old female patient, complaints of cardiac pain and rhythm intermissions. Notice the blood pressure. Patient is in shock. Jet pulse is 220 beats per minute for commission. Now, extension and deformation of QRS. See, when you are seeing a like patient is in fibrillation at this level, 220 beats per minute with deformation of QRS and so on, you can read further. Which of the following be the most effective treatment in this kind of patient? You are going to be needing an artificial pacemaker. 26-year-old female patient has 11-year history of rheumatism. 4 years ago, she suffered 2 rheumatic attacks. Over the last 6 months, there have been paroxysms of atrial fibrillation every 2 to 3 months. So, what option of antiarrhythmic therapy or tactics should be proposed? This is a patient that is having arrhythmia. So the best thing to give to as prophylaxis and even possible treatment in this patient is to give an antiarrhythmic drug. So the best to give in this case is amiodarone. So the best answer similar to amiodarone here is prophylactic administration of cordarone. Cordarone is amiodarone. Amiodarone is class 3 antiarrhythmic drug. All right. We have a 49-year-old patient. Notice dyspnea and cough, and there is no sputum discharge. Repeated use of salbutamol and inter, but no effects. You couldn't reverse the bronchoconstriction. So what do we know? We notice that pulse, there's tachycardia. This is relatively normal. There's no peripheral edema. What is your provisional diagnosis? You will notice that they didn't tell us that the patient was a smoker or something that would actually make us to conclude that okay, that this is chronic obstructive bronchitis. No. So the best option in this case is that this patient is a patient with status asthmaticus. That is not responding to the basic treatment of asthma. Thrombosis of coronary artery caused myocardial infarction. What mechanisms of injury will be dominating once in this disease? Looking at this question at first, I thought it was going to be acidotic mechanism, which is true. You have that in infected tissues, but the fact is there's something called like a calcium scan, or so there's something called a calcium scan. The results could actually help a patient to evaluate the risks of that patient in developing myocardial infarction in the future. This is because in normal coronary arteries you do not have calcium, but calcium influx or the presence of calcium deposition in these coronary arteries directly corresponds with development of myocardial infarction. So that is like the little way I can justify this answer to the calcium mechanism. On the second day of the disease, a 22-year-old male patient complains of high-grade fever, headache in the region of forehead. When you read further, with aching muscles and joints, temperature of 39 degrees. I expect you to try to come up with differential diagnosis, and I think for me the best differential here is influenza, is flu. And it is flu. One thing about flu is that they said what change in hemogram are typical for this disease, and flu is closely associated with leukopenia. Again, we've seen this question, this particular question over and over again in different formats. A patient with interdigital fold, is this sounding familiar? Scabies, flexors of, like we have lesions there, like flexors of wrists and so on. Then the rash is accompanied by skin itch that is getting stronger at night, scabies. So what external treatment are you going to administer? Just try to know the treatment. One of the basic treatment for scabies is to use 20% benzyl benzoate emulsion. Alright. Personally, looking at this question, I think is simply obstructive type, because you look at the FEV1 FVC ratio, it says 50% is very low in obstructive diseases. I cannot really lay my hands so much on reason for the restrictive disease in this particular patient, except that barrel shells can be in obstructive disease and in some rare occasion in restrictive disease. So determine the type of respiratory insufficiency. The correct answer in this case is mixed type, but with prevailing obstruction, which is very true. Obstruction is what prevails in this particular case based on FEV1 FVC ratio. Alright. An ambulance had been called to a 48-year-old man. According to his relative, the patient had 3 attacks of unconsciousness. So a patient is having convulsions together with unconsciousness. 3 attacks within 24 hours. This is not just basic seizure. This is like here we are having epileptic seizure. The attack lasted 1 minute and ended in involuntary urination. Despite this kind of epilepsy, it's typical for epileptic seizure. Unlike syncope, as we saw previously, that the patient was in a stuffed room. Alright. See, again, this is like diagnosis of exclusion. You exclude the options. It's a 60-year-old patient that just lost the husband. So a combination of the age together with the fact that she's in a mood that could actually place her in depression. So patient is beginning to lose function of her cerebrum, forgetting things, emotion is affected, and so on. So you can see mental status, there's temporal disorientation, and so on. So this is just in simple terms a patient with atrophy of cerebral cortex. Take note of this question, please. Atrophy of cerebral cortex. No. All right. A 26-year-old patient has abused alcohol since the age of 16. This is interesting. So, and is a motor mechanic. Over the last 2 years, work zombies have become more frequent. What medical and tactical actions should be taken? Already this is affecting his work and he's getting drunk and so on and so forth. However, the patient that is abusing alcohol, we still need to make sure that his consultation is voluntary. It's voluntary and it's something addictive. So voluntary consultation and treatment at an addiction clinic. All right. When you have an history of ulcerative colitis, 8-year history of ulcerative colitis, patient that been treated with glucocorticoids and so on, but notice in this particular question, alongside with diarrhea and so on, that the left iliac region has significantly increased. So one of the complications that can arise from ulcerative colitis is the development of a megacolon, and in megacolon patient can have shock, patient can develop shock and so on. So what complication develop in this patient? The answer is toxic dilatation of colon, that is toxic megacolon. 26-year-old patient with left lower lobe pneumonia experiences an acute chest pain on the left during coughing. Whatever it is that you are experiencing when you are coughing, or there is deviation of right cadral border towards the midcap, what examination will be the most informative? So no respiratory murmurs, let's just go for our chest X-ray. It's always very good. As we've been seeing, we've explained that over and over. A male patient presents with swollen ankles, face, eyelids, you see, elevated blood pressure 160/10, daily loss of albumin. So this is a patient that is having renal pathology. Together you can see that there's nephrotic syndrome. This patient is developing possibly glomerulonephritis, and we might need steroids to reverse that, corticosteroids. All right. We have a patient with aftermath cardiac infarction. Patient has developed attack of asthma. Sometimes when the heart is beginning to fail, one of the things that can happen is that patient can develop asthma, the so-called cardiac asthma. And we have pulse of 108, arterial blood pressure of 150. That is the word, and mixed moist rays can be heard over the entire surface of the lung. So you're having pulmonary edema because of the heart pathology. What drug is most effective in this situation? Actually, the best drug to give is that, you see, dopamine is used when the blood pressure is low. You see the blood pressure here. Aminophylline is like the same group as theophylline for bronchial asthma, so that's not what we need here. Strophanthin will help in cardiac contractility, that's not really what we need. So we need something that can dilate vessels, that can decrease blood pressure, decrease oxygen demand of the heart and so on. So in this particular case, we are going to give nitroglycerin now intravenously. In angina pectoris, we give it first sublingually. All right. During dynamic investigation of a patient, the increase of central venous pressure is combined with the decrease of arterial pressure. What process is proved by such combination? Okay, I don't really know the reason why they shows this answer. A combination of increase of central venous pressure with decrease of arterial pressure. Here they said the process is proved by combination of increase of bleeding speed. But however, we know that in the process of hemorrhage during bleeding, there's centralization of our blood supply to vital organs, the heart itself, the brain, and the kidneys. So peradventure, the increase in blood flow to the upper part of our body is part of what is causing increase in central venous pressure, because as more blood flow to the brain, we also have more blood returning from there. So possibly that's the reason. A male patient complains of heartburn which gets stronger while bending the body. Substernal pain during swallowing. There is hiatus hernia. Hiatus hernia on X-ray. So when the patient is having hiatus hernia, definitely there's going to be excessive relaxation of the lower esophageal sphincter, and that is going to give room for gastroesophageal reflux in the patient. So that is what you are going to find on gastroscopy. He's a 43-year-old male. Again, we've seen several of questions like this, and they're telling you about the bowel movement and so on, but these symptoms have lasted for over 3 months. Constipation, diarrhea is looking familiar. Now, no changes in laboratory tests. When you don't find any changes, please just go for irritable bowel syndrome. In one of the questions, we had the answer to be irritable colon syndrome. It's still the same. So here, patient background of angina has developed pain in the tubular bones. Examination revealed generalized enlargement of lymph nodes and hepatorenal syndrome, hepatospleenic syndrome, sternagia. See, notice blast of 87%. 87%. So what is the most likely diagnosis? See, it's in acute condition that you have such high level of blast. If it is myelogenous leukemia, it will be high level of blast. It is lymphoblastic, also you see high level of lymphoblast. But in this case, you can see lymphocyte and blast is everything. So, but they made it just very simple: acute leukemia. In chronic lymphocytic leukemia, they are going to tell you about smudge cells. In chronic myeloid leukemia, they will probably want to tell you about Philadelphia chromosomes. In multiple myeloma, they might want to tell you about Baines-Jones proteins. In erythema, that's polycythemia vera, you see the blood erythrocyte level is going to be very high. So, blast said simple is acute leukemia. Now, maybe in case you are hearing a voice in class that is telling you to go home, you might need to take your time well. That voice might just want you to have embed. A 49-year-old female patient with schizophrenia. See, it's as if there's a phone in her head, and she hears the voice of her brother who tells her to go home. The patient is anxious, suspicious, looks around all the time. See, this patient is just hallucinating. Let the patient go home. For a 3-year-old patient, thrombocyte level, you would notice, is 50, and as a result of peptic ulcer, patient is bleeding already. So I'm just asking us, in this case, it is most rational to administer the following preparation. They are supposed to tell us the blood pressure in this case, but they withheld it. I don't know what they want to use it to do. But however, we are going to administer fresh frozen plasma for this particular patient. Correct bleeding, so on. All right, I just spoke about a cancerous condition in which we have smudge cells. Can you see? Smudge cells was found, and see all this condition of cancer, you can see everything here. You can just take to it, but when you see small cells, it's chronic lymphocytic leukemia. I can see lymphocyte level to be 3%, lymphoblast to be 2%. If it is an acute lymphoblastic, it will be so much, the lymphoblast will be more in acute condition, but in chronic condition they have been the body has stratified that compensation and so on. So this is a chronic lymphatic leukemia. Chronic lymphatic leukemia. All right. This patient is seen all the results and so on. Then in the blood analysis, you have seen blast of 4%, but leukemia is suspected. See, white blood cell 3. This cannot be leukemia, but however, it could still be. See, myelocyte of 25% is not normal, but myelocytes. So I still suspect some extent acute myelogenous process here, but we cannot conclude. But what do? You need to do standard function. When the patient is having leukemias or hematological cancers, it's best to do a standard function. All right, we have a 24-year-old patient putting on weight. Patient is gaining weight. Limosis. Limosis means increased appetite. Increased appetite. So it's just like the opposite of anorexia. Patient conditions of hyperstenic type, body weight index. This is like body mass index. BMI is 33.3. That is enough to answer this question. What is the most likely diagnosis? Together with this, if not to use it, the waist circumference and thigh circumference, but this is not up to this, so we don't have up to 1. So number 1, because there's increased appetite, this is a alimentary kind of obesity, not Cushing's. Cushing's is going to be disorder of the excessive secretion of cortisol and so on. So the answer is alimentary condition. So is it this or this or this? But the fact is BMI is 33. BMI of 25 to 30 is overweight. Of 30 to 35 is first degree obesity. Then 35 to 40 is second degree. Then greater than 40 is third degree obesity. So this is 33. This alimentary conditional obesity first degree. Even if we are not very sure whether it's abdominal type or gyne type, this is the only option that have first stage. But we can see the circumference here of the waist is 100 centimeter. All right. We spoke earlier that we had a patient then that couldn't walk up to 100, 200 meters and so on. But here we also have a patient with ischemic heart disease, drinks 2 liters of beer. He walks a distance of 700 to 800 meters. You see, notice blood pressure is still normal. This is normal. ST segments, depression, fever to V6. What is your most likely diagnosis? But don't forget that that occurs when he walks. So this is stable. So is it 4? Is it 3? Is it 2? In fact, it is 2 because it can walk a very long distance. In 1, there's no presentation to such a long distance, but you live by rest. In 3, in a very short distance. Question 39. See, I told us earlier in one of the questions that if the answer is going to be scleroderma, they will tell you about dysphagia. They will tell you about things that will point your attention to manifestation of the Crest syndrome. So 53-year-old patient complained of sensation of numbness, sudden painfulness of 2 to 4 fingers, muscular rigidity, see, dysphagia, polyarthralgia, constipations, dry race in lungs. This is straightforward. This is systemic scleroderma. All right. 45-year-old patient has been exhibiting high activity for the last 2 weeks. He became talkative, euphoric, had little sleep, claimed being able to save humanity and solve the problem of cancer and AIDS. Gave money to strangers. In case you've ever felt like this, I think yours could be normal. What is the most likely diagnosis? this patient is having the onset of this is called maniacal onset. It's not depression, it's not panic disorder. The best interpreter is patient is having like, is it grandiose? A patient had 4 generalized convulsive seizures within a day. Between the seizures, the patient did not come to waking conscious. That the patient is unconscious. You see, when a patient is unconscious, as the patient is having seizures, most of the time, that patient is already in a state of status epilepticus. All right. 35-year-old patient complains of heartburn, sore eructation, burning, and retrosternal pain. The patient hasn't been examined, takes Amagel on his own initiative, claims that that's an antacid, claims to feel better after taking it. So just make a provisional diagnosis or preliminary diagnosis. You can just think of GERD, gastroesophageal reflux disease. As a result of lifting a load, a 62-year-old female felt acute pain in the lumbar region. Acute pain in the lumbar region. This is looking like lumbar radiculitis that we saw in one of the questions. Weakness of anterior tibial muscles, low Achilles reflex on the right, positive LASIK sign. You see, it sounds familiar. So what examination would be the most effective? In the previous question it was, what examination would be done first? Here they said would be the most effective for specification. And you might not be able to do this with an X-ray. See, these are very few exceptions where X-ray will not be the answer. Most effective for specification of this L5 route. The best thing we need to do is to do an MRI. And thank God there is no CT in the option to confuse you. So MRI. You see, we have a patient with weight loss, loss of appetite, and everything that is pointing as if the patient does not have stimulating hormones in her, okay, female patient. So blood pressure of 70/40, bradycardic, patient is bradycardic, and reduced concentration of aldosterone and cortisol in blood. Decreased concentration of 17 ketosteroids. You see, aldosterone, all these things are produced by the adrenal cortex. Aldosterone, 17 ketosteroid, normally it is high in steroid diabetes, but here it is low. It means that cortisols are not being produced in adequate amount. Aponatremia is due to low level of aldosterone and so on. So the question is, what therapeutic measures are required? Of course, give the things that are missing. Give glucocorticoid, give mineralocorticoid, and to increase sodium level, you are permitted to take more salts in this case. Here is a patient that I think seems to be schizophrenic. 23-year-old female patient has mental disease in the age of 18. The cause has no remission periods. Patient non-pulseful foolish excitation, stereotypic grimaces, masturbating in front of light out, repeating the stereotypical abusive shouts. The patient should be assigned, just give an antipsychotic drug, neuroleptics. All right. You see, this about a patient that is dependent on alcohol. This state developed a day after a regular drinking bout. Patient resided in Neurological dispensary. You see, narcologists, they are in charge of drug of abuse. The psychic orientation is distorted. Patient presents motor anxiety, fear on his face, talks about his problems and asks to release immediately because he may be killed. The state developed a day after a regular drinking bout. So they are telling us about patient that's been taking alcohol. So what is your provisional diagnosis? When patient is manifesting psychosis or delirium or symptoms like this, is usually as a result of alcohol withdrawal. And such condition, you call it delirium tremens. So there is no alcohol delirium in this question, as in previous videos to have confused us. So this is delirium tremens. Number one, notice that this is a young patient. Pulse and blood pressure is normal. So when you hear, and there are no particular changes in ECG, when you hear S3 sounds in an hypersthenic or in an asthenic rather, asthenic patients, together with the fact that the patient is young, S3 in such condition is going to be physiological, that is normal without pathology. So it's physiologic S3. Okay, all toenails are grayish yellow. Varix dilatation of lower extremity veins. This is typical for rubromycosis. 14-year-old patient with signs of internal hemorrhage has been taken to a hospital after a fight. He has had hemophilia A since childhood. He has been diagnosed with peritoneal hematoma. So we spoke earlier that the patient is having deficiency of a clotting factor. You give fresh frozen plasma. Now, fresh frozen plasma is different from fresh blood. They are different. So the fresh frozen plasma is all cryoprecipitate. So the answer is cryoprecipitate. Okay, we have an hypertensive patient. You can read the initial history. Hypertensive patient. ECG shows signs of hypertrophy and left ventricular overload. What is the most likely diagnosis? There's something we've omitted in this question. Auscultation reveals some fine nostrils in the lower part of the lungs. So the underlying disease here is the hypertensive crisis that is causing pulmonary edema in the patient, because the patient needs to pump against higher pressure, which makes some blood to be retained in the lungs. Complicated hypertensive crisis, pulmonary edema. There's no infarction in the patient. It's not bronchial asthma. It's not pneumonia. So it's complicated hypertensive crisis. All right. When they are telling you about the spine, say lumbar spine, pain in the lumbar spine, with history of focal tuberculosis, you can begin to think that the tuberculosis also might be having tuberculosis of the bone as well in this patient. So that is the reason for all these X-ray pictures shows destruction of adjacent surface of 1 to 2. The answer in this case is patient is having tuberculosis, and then you are having pain in the bones and everything. This is going to be tuberculosis of the bone. So the answer is tuberculosis spondylitis of lumbar spine. It has another name. It is also called Pott's disease. P-O-T-T. Pott's disease. All right. Okay, we have a 43-year-old female patient who was delivered to the hospital in grave condition. Patient had history of Addison's disease, adrenal insufficiency. Okay, see, the arterial blood pressure is very low. Sodium is down. Potassium, I think this is elevated. Development slightly. Development of this complication is primarily caused by deficit of which of the following hormone. And here we have Addison's disease. But how do we know which of these hormones, whether it is ACTH or whatever, because they said this mucous membrane is pigmented. But notice something, they said the patient had been regularly taking prednisolone, but a week before she stopped taking this drug. So a week before the manifestation of this symptom, patient was on prednisone. So when there is withdrawal, there's going to be development of adrenal insufficiency, because patients have been dependent on exogenous steroid. So that is the reason why what is the primary cause of this in this patient is cortisol. All right. See, patient was pulled out of open water. I don't know why they like going. It was water. There was no respiratory contact with the water. Good for the patient. Normal. Slightly tachycardic. Temperature is low, but at this level of 34.5, this is rectal temperature. At this level of 34.5, What patient needs is passive warming. Passive warming can even be done with certain warm jackets. All right. But they are giving, okay, they say that a patient, a 52-year-old worker, agglomeration plants, concentration of metal dust. When I'm hearing about metal, I don't really want to take my time anymore. I'm thinking of, you see, siderosis, the word else, or the sidero, it means the iron man. So I'm talking about metal here, so none of this fine dust. So siderosis. Alright. 69-year-old patient, primary sensation of heaviness and fullness epigastrum, in shakiness after eating. You see, foul smelling eructation 1 to 2 days after eating. Weight loss. So it means that the food that this 60-year-old patient is eating is not passing down. That is why a patient can eat it and after 1 to 2 days still regurgitate it, have it, the food regurgitating back. So it was found to have had ulcer of pyloric channel. So the best thing that describes this symptom in this patient is simply pyloric stenosis. Stenosis is also part of the complications of an ulcer. All right. They are telling us about a patient, a secretary. She's always, of course, using her hand typing, working ability to type and write. Now she's having ability to type and write. Up to 80% of her works involve the hand load. The right hand is tense. There's increase in muscle tone. Attempts to write cause spasm. No pathological changes of CNS. What is the most likely diagnosis? So they are telling us that there's increase in muscle tone. That is spastic. So we are talking about spastic form of coordination neurosis. All right. Electric welder, 15 years of service. Electric welders, they solder on iron and on different things. Radiograph shows diffuse nodule size 3 to 4 mm in the middle and lower lung phase. What disease can be suspected in this patient? The answer is heavy metal coniosis. So they work on metal as well. Okay, again, a vegetarian, signs of malnutrition, consulted doctor, smell and taste distortion. I'm thinking of iron deficiency. See, the patient was diagnosed with iron deficiency anemia. What is dominating clinical syndrome in this patient? Is iron, the iron man, sideropenic. All right. When a patient is losing 10 kg, such weight loss, thinking of cancer, with a external pain, that 10 kg is within 3 months, within a short time. And patients having hypochronic anemia and so on, together with this word that I wasn't so familiar with, positive Gregg-Gassens reaction. Esophagram revealed feeling defect with ill-defined serrated edges. So what is the most likely diagnosis? Combining this and this, feeling defect, esophageal carcinoma. All right. Look here. Sometimes you find your friends, all of a sudden they are just absent. It's not all of them that are actually lost in thoughts. Some persons, though it's not what requires treatment, are having absent seizures. So a 12-year-old boy periodically has 12 episodes of brief loss of awareness, taste, look, and eye stay in upright position. It shows that patient has a subsequent amnesia, blank expression of face. Specify the described states. You can find this in also some of those your colleagues in class that laugh last at the joke, probably they were having absent seizure. 19-year-old male patient complains of intense pain in the left knee joint. Left knee, intense pain, 19-year-old. So what are you thinking already? They didn't tell us about trauma. So already we are looking at everything, telling about rheumatoid factor is negative to let us know it's not rheumatoid arthritis. Together with all these things, this is a patient that is having hemophilia with spontaneous hematolosis bleeding into the joints. Okay, when there's an outburst, when there's an outbreak of something poisonous, explosion of a tank of benzene, there are over 50 victims with burns. The fact is, as an emergency doctor, what will you do? You want to sort out patients. These ones are injured, these ones are not injured, you sort them out. After you might have sorted them out, you start to attend to them from there, and then you have to take them away from that region. So it's simple. So that is sorting, medical assistance, then evacuation plan. Emergency doctor has diagnosed a 2-year-old man with generalized convulsive status epilepticus. Generalized convulsive status epilepticus. The deterioration in patient's condition is caused by sudden gap in epilepsy treatment. Specify the doctor's further tactics. You see, once a patient is having status epilepticus and the patient is to be admitted, that patient should be admitted in the intensive care unit. The patient is going to need oxygen and different things. All right, we've come across this question a lot of times. What combination of drug be most effective for secondary prevention of heart failure? Please, let's have it at the back of our mind. We'll be hearing these kind of questions. So this is best answer is beta blockers and ACE inhibitors. Beta blockers and ACE inhibitors. That's one of the drugs that decrease mortality rates in patients. Attack of retrosternal pain that lasted more than 1.5 hours in a 57-year-old patient. ECG shows ST elevation, lead 2, 3, AVF leads. You see, heart rate is normal, but we are having shock in this patient. What conditions are these changes typical for? You know, you might want to think of acute pericarditis because of the attack of retrosternal pain, yes, but this patient is having shock. Right now we are thinking of cardiogenic shock. The retrosternal pain might have even been due to myocardial infarction, then leading the patient into cardiogenic shock, and we have ST elevation. So where is it? Cardiogenic shock. All right. Again, my eyes is seeing at first color index of 0.78, which is low hemoglobin. So 42-year-old patient lives in the basement, unemployed, undernourished, hair loss, brittle nails, likes to eat, shock, pica, change of nutrition in iron deficiency anemia. We shouldn't take our time anymore. Nutritional iron deficiency anemia. A 20-year-old patient complains of breath shortness, continuous dull heart pain, irritability. You see, this is normal. Patient has been diagnosed with cardiac type neurocirculatory dystonia. The patient should receive treatment under the following conditions. See, this is relatively normal. Continuous dull sound. According to the question, this is a patient that we can manage as outpatient, especially patients that are having a rest. Right. See, what is most likely diagnosis in a patient that is having positive personality symptoms, which is acute pain in right side, radiating to the right thigh and crotch. The patient has no previous history of this condition, and you'll be seeing in some other conditions it resembles mid-slopes, frequent urination. This is urolithiasis, positive paternity sound. Also, you could find it sometimes in acute nephritis, but mid-slopes. 38, and they want to give us temperature too in pyelonephritis. A 38-year-old male works within the range of ionizing radiation. You see, if ionizing radiation is causing a patient to have a thrombocyte of 30, in which normal is 180 to 320, and such low level of white blood cell, it's hemoglobin of 80, at this level, I think permitting the patient to walk is directly proportional to permitting the patient to die. So, working with radioactive substances and other sources of ionization is contraindicated. Alright, we have a patient undergoes treatment at a tuberculosis clinic, has complained of having progressing headache for the last 3 weeks. Neurological examination reveals rigidity of occipital muscles, no focal symptoms. What is your professional diagnosis in a patient with tuberculosis? This patient is having tuberculosis meningitis, just like one of bone. Right. A patient with chronic suppurative otitis had developed severe headache, vomiting, and body temperature rise. So we are thinking that place is very close to the skull, to the brain. And meningeal symptoms are now present. You want to ensure what is going on in the brain. And how do you do that when the patient is having meningeal symptoms? You have to check the CSF. So, urgent hospitalization and diagnostic lumbar puncture. A 28-year-old male patient complains of sore regurgitation, cough, and heartburn that occurs every day after having meals. When bending forward or lying down, these problems have been observed for 4 years. You see, esophageal gastroduodenoscopy revealed endoesophagitis. What is the leading factor in the development of this disease? When bending forward or lying down. So here is going to be the failure of the lower esophageal sphincter. Routine examination of a 16-year-old boy revealed the presence of 3 heart sounds on auscultation. Notice again, a young boy, 16-year-old, and every other thing is normal except for pneumonia in the history. So they are about to tell us again, why is there third heart sound? In this age, it is physiologic third heart sound. Alright. A patient's condition is getting worse towards evening. She becomes excited. There's something, feeling that weight on her heart, something evil will happen to her family. Patient is sad, has poor appetite and sleep. Specify the kind of mental disorder. In this particular patient is anxious. It's anxious depression. When they tell you about tuberculosis, and they tell the intensity is up to 1 centimeter, you are thinking that this is infiltrative form of tuberculosis. And when they also tell you that there is destruction area in the center of the shadow, it means it is disintegrating. Double combination, infiltration and disintegration. Alright. In a patient that is suspected to be having leukemia, and in this condition you are seeing blast to be 52%, and reading of all the other cases as we've seen earlier, what test is required to specify this? Now we will have done lump or standard puncture, but we don't have it in this case. The best answer here is to do immunophenotyping. In immunophenotyping, again, is a technique to dictate specific proteins that are released by cells, and in this condition, we want to check for certain markers of cancerous cells. That's immunophenotyping. This is the last question of Internal Medicine 2014, and I hope that you have been enjoying the study so far. 47-year-old male patient complains of comprehensive chest pain that occurs both at rest. You just continue to, and this problem arose 3 months ago. The patient's brother died suddenly at the same age of 30. So you notice in young patients and with same history, you are thinking right now of, and you are seeing left ventricular hypertrophy. You are thinking of hypertrophic cardiomyopathy. And also echo revealed intraventricular septum, but they are telling by intraventricular septum about 1.7 cm or whatever. You are thinking of hypertrophic cardiomyopathy. So have a beautiful day. God bless you.